Thanks so much for inviting me to be here today. It's awesome to talk about team-based care. I think this is an excellent area of practice where having multiple clinicians and professionals on the team really allows the patient to be successful. And our patients specifically at UCSF find a lot of value in having different experts on their team to be able to answer all of those questions that they have. So as the pharmacist in the clinic, I will be focusing on the role of the ambulatory care pharmacist. So I always like to explain, to others that we practice as an extension of the cardiologist. We're similar to a nurse practitioner or a PA, where we work really closely with the entire care team, but we don't do any of the diagnosing, but rather once there's a diagnosis, then we help to manage the medication component of the patient's care. So I thought this was helpful to start at the beginning. It's something I find super interesting, and you all may know already, but the timeline of medications when it comes to lipid-lowering therapies. We can see back in 1987, that's when the first statin was FDA approved. And then as you go to the right of the screen, you'll see, in the 1990s, we didn't really have a lot of movement from a medication perspective. Obviously, there were other statins, and we know there are multiple statins now available, which I'll touch on a little bit later in the presentation. But it wasn't until 2002 where we had the Zetia prescription with a different mechanism that was FDA approved. And then again, we go into 2015, where we see the PCSK9 inhibitors like alirocumab and evolocumab, and really now into the 2020s, where we see new medicines such as bempedoic acid or inclisiran. And so I bring this to point in that we have a lot of options in order to be really patient-specific in our care. There's not kind of a one-size-fits-all anymore, and it's really important that we take into consideration all of the other medicines and different comorbidities that the patient may have to best find the agent that they are able to tolerate the best. And as Dr. Stock talked about, getting that LDL to the goal of, less than 170/55, where the patient is at, that's a really important part as well. I thought this was helpful, and I'm sure Dr. Knowles will talk more about this, but I ran a report here at UCSF Cardiology since 2019 to March 2025. This was for the cardiology department specifically at UCSF, and I looked at how many of these patients that we've seen that have had an actual scheduled and completed cardiology visit. How many of our patients had lipoprotein A specifically ordered for them? This doesn't encompass patients who may have had it already completed at an external facility, because I wasn't able to pull Care Everywhere data quite yet before this presentation. So 6.3% of patients who had a cardiology visit had lipoprotein A ordered. I think this is a super important thing as we look forward, and how can we improve this number? And that's why having multiple visits with these patients, whether that's with a pharmacist, an APP, a dietitian, can help to catch these patients who maybe haven't had this lab specifically ordered for them. So the more people we have on the team that can look at these patients and assess their individual risk, I think our outcomes and percentage of this being ordered will continue to increase. So what I'm hoping to mostly talk about today is team-based care and how having a pharmacist on the team really impacts the patient. So when we think back to maybe when pharmacists weren't integrated into the clinic and, only in a pharmacy-specific setting where we were doing mostly dispensing responsibilities, patients would likely get a high-intensity statin prescribed they would be told to take daily, and then see their physician, primary care cardiologist in 6 months. Obviously, this isn't everywhere now, and I think patients often can receive care sooner, but they didn't have a lot of touch points in between there. And so now what we like to do is we have everyone collaborate on the entire care team to reach these goals. So we consider statins based on patient specifics. We don't just give one statin to everyone at one specific dose. We really look at all of their medications, and I'll talk a bit more about like CYP enzymes and things as it comes up to personalize that. And then we have the patients follow up closely with the pharmacist, the dietitian, and the cardiologist, as well as the APPs, to make sure that they're getting to goal. One thing I really love about that timeline of medicines, and we've talked a little bit about here too in some of the studies that Dr. Stock shared, was the utilization of non-statin therapies. This is super helpful for patients who maybe are statin intolerant, or maybe they aren't able to tolerate a high intensity statin, and something that I really like to discuss with patients that I see is that it's not a one size fits all. And while we always want patient on a statin, even at a minimal dose, it's not the only option that we have. And so we can utilize the studies to see which specific non-statin would fit their profile the best. The most important thing that I like to note and sometimes can get overlooked when thinking about team-based care is what we call a warm handoff. So if patients come to me or are on my schedule and their cardiologist hasn't really explained to them the purpose of the pharmacist visit, they're often confused, right? Having a pharmacist in the clinic isn't necessarily something that's been around for hundreds of years, where like a specialist and seeing a cardiologist has. And they really trust their cardiologist. And so having them be able to have this warm handoff where the cardiologist explains to them why they're seeing the pharmacist, what the pharmacist's role is on the team, and all of the responsibilities that a pharmacist is able to handle independently in the clinic allows for a really successful first visit and then also follow-up visits. And so this is just an example of something that Dr. Stock includes in her after visit summaries if she were to refer a patient to our pharmacist team. So not only that actual in-person conversation, but then just a reminder of what is the purpose of the visit really allows our patients to understand and ultimately schedule the pharmacist visit. So what's the role of the pharmacist in our clinic, or how does this work from a logistic and clinical perspective? So we have to have a referral in place. So pharmacists can't practice independently at UCSF without this collaborative practice agreement. And so we have a referral that's placed from the cardiologist to the pharmacist, and that referral initiates our collaborative practice agreement. The collaborative practice agreement that we have decided on is between one physician or APP and one pharmacist for a specific patient. That means that every patient that you want to see the pharmacist has to have their own referral in place. After the referral is placed, the pharmacist meets with the patient. We do via Zoom and in person for education and medication management. One thing that I really like to note here, and as the landscape continues to change in terms of telemedicine, is the telehealth visits. I would say at least 90% of our visits are performed via Zoom. And I think this is a really important piece, and hopefully we can continue to keep this modality of care for our patients, because we have patients who live, 3 hours outside of San Francisco. And if we're managing their lipids and are able to see their labs, the pharmacist isn't doing a physical assessment on the patient. And so being able to access them via telehealth really allows them to get to goal much faster. And then we have multiple collaboration along the way. So we collaborate with the entire care team to optimize medication. So whether that's endocrinology or primary care, we really try to be the hub for the medicines to ensure everyone's on the same page in terms of why the patient's on certain medicines and help to fill any gaps in care from that perspective. We continue to see the patient for hyperlipidemia or the other disease states that we're helping with until the patient is at goal. Once the patient is at goal, we graduate them from our pharmacist program, and then they're referred back to the cardiologist. So this would be like if the patient's, LDL goal has been less than 55 and we've done a follow-up at 6 months and it remains at goal, we wouldn't continue to see them for ongoing care at that point. One thing that we have, and we're very lucky within the division of cardiology, is we have pharmacy technicians embedded in our clinic as well. I think this can be overlooked in other clinics where there's other clinical or non-clinical members who are completing the prior authorizations or doing any medication access related activities. In our clinic, we have 2 pharmacy technicians who handle all the prior authorizations and anything med access related. And so anytime a medicine is prescribed within a cardiology department, our pharmacy technicians get an electronic prior authorization, which they're able to complete within Epic. Not everyone comes electronically, but we've really streamlined this process. And then the prescription's actually not released to the pharmacy until the prior authorization is approved. This helps with multiple calls to the clinic, which often will take up the time of nurses or other staff if pharmacies or others are asking about a prior authorization update. Within the division of cardiology, our technicians have greater than a 95% approval rate for all cardiology medicines, which is tremendous and significantly higher than some of our colleagues in other clinics that don't have a pharmacy technician embedded, they have access to us, the pharmacists, and they also have a little bit more knowledge on the actual medicines and are able to complete the prior authorizations timely and include additional clinical information to ensure the prescribed medicine is getting approved. We all know that sometimes medications are expensive for patients, and that can mean something different to patients. You know, someone might be able to spend $500 a month on a medicine, and then another patient, you know, if it's $10, that is something that's not doable for them. So we really meet the patient where they're at financially and are able to provide a lot of different resources in order to get them the medicine in their hands. We know that even if we prescribe it, there's a lot of things from prescribing it to the patient actually taking it from a cost perspective. And so our technicians really help to follow that from the very beginning to the very end. And then the patient's able to start their medications and hopefully improve their outcomes. One of the major challenges in terms of having a pharmacist embedded in the clinic is reimbursement. So this varies depending on the state in which you practice in, and I've been lucky enough to practice in a couple of other states where the laws are a little bit different. So I've been able to see some areas where it's a large challenge, and then other states where pharmacists have the ability to bill on a larger scale. And so we continue to advocate for our opportunities as we really understand the value. And this is something that I hope everyone will continue to think about, as right now we're in our specific clinic, we're only allowed to bill a 99211 code, which, as you know, is a very minimal, some might describe it as a 5-minute code, and you know, reimbursement could be about $20. These visits that we spend with patients are up to 60 minutes, and we provide significantly more value than what we're able to bill at the moment. And while we can continue to show quality improvement outcomes, revenue is also super important. So this is something that I hope we can improve on. So this really just talks about what, and again, I won't touch on it too much, but what the value of a pharmacist visit is, what we do during our visits in terms of explaining to the patient how the medication works, you know, really looking at the trials in terms of what % lowering will we get with Zeti versus bempedoic acid versus a PCSK9, and what % lowering do we need to get the patient to goal. This shows you, again, the statin metabolism. I really like to explain to patients that not all statins are the same. And depending if they're on, you know, certain medicines that might inhibit 3A4, looking at a different medicine might be a better option for them. Also describing to them the differences in statins. You know, we have hydrophilic versus lipophilic statins, and so a lot of patients aren't familiar with what that actually means, and explaining that to them allows them to understand that even if they've tried maybe atorvastatin 80 and didn't tolerate it, it's not the only option we have. And then this is the last thing I just wanted to share. I looked back at the data from the last 1 year, so March 2024 to March 2025, on patients that I saw in the clinic, and 77% of patients who I saw for a reason of visit of hyperlipidemia had an LDL that was less than 100. We've since added 2 more pharmacists to the team, so hopefully in the next year we'll be able to continue to improve this.